we just started our recording of this so that you can access the live webcast following this session today. And I just wanted to get started before we take up too much time in the beginning. So my name is Marissa Tonelli. Thank you guys so much for joining our PrEP policy learning series for Medicaid and public health officials. I run our 3D, Health HIV's 3D HIV prevention training and TA program. And one of the projects we've been working on with the team at the National Academy for State Health Policy, NASHP, is this PrEP policy learning series. And today our specific topic we're focusing on is navigating the HIV data landscape and understanding the practical and legal challenges of HIV data disclosure. We have some great speakers from both federal and state agencies with us today to share best practices. I'm going to skip to logistics. So everyone's line is open. If you could please mute your line if you're not speaking. That will reduce the echo that I'm hearing, please. Could everyone please mute your lines or your computers if you're using computer audio? Thank you. So the lines will be open during the presentation. And if you're not a presenter, you can access audio via dial-in. Okay. Could you please mute your lines? I'm still hearing myself if you don't mind. Okay.
Ladies and gentlemen.
Michael, that might be on your end. Oh.
We do have an audio feedback issue.
Are you still there?
Marissa?
Okay. Yeah. Okay. We might want to we might have to close the conference line for a second. Okay, so I'm going to move on. So we can use the Q&A box for questions, any logistical questions, and use the chat box to leave a comment. That's the little bubbles on the screen. We will be completing the evaluation of the webinar. We'll send out to you. It'll come in a link from the platform after the webinar. And we'll also have available for download the slide deck, the webinar recording, and resources for sharing. Okay. Our webinar objectives today are to discuss the federal and state statutes that govern data sharing across agencies, describe how to establish data use and disclosure agreements between state agencies, and discuss promising practices and lessons learned in overcoming common challenges to establishing or expanding data use and disclosure agreements. We also have some great speakers with us today. And again, just want to remind everyone to mute your lines, please, because we're still getting a feedback. We have Lindsay Sanborn, who's going to be co-facilitating today. Lindsay is the Policy Associate at the National Academy for State Health Policy. We have Morris Landau, the Supervisory Program Analyst and Privacy Branch Chief at the U.S. Department of Health and Human Services. We are joined also by Wendy Levy. She is the Section Director at the Medicaid Finance Systems and Research at the New York State Department of Health AIDS Institute. And also Catherine Macomber the manager of the HIV, STD, TB, and viral hepatitis epidemiology section at the Michigan Department of Health. So without further ado, I'm going to turn it over to Lindsay, and she will facilitate the next discussion around the agenda and introduce our first speaker.
Thank you, Marissa. My name is Lindsay Sanborn. I work at the National Academy for State Health Policy, and I'm thrilled to be helping to facilitate this webinar. And I hope you all brought your questions with you, because this is a great opportunity to really hammer out some of those nitty-gritty questions that you have regarding data use agreements and data sharing. So today's agenda includes brief introductions, establishing data use agreements, federal and state statutes covering HIV data disclosure, and then we have two peer state presentations, one from New York and one from Michigan. We'll have time for questions and answers after each presentation, but we'll have a little bit more time at the end to really get into some further and broader discussions regarding data sharing and some of the challenges that your state might be struggling with. We'll move on to closing remarks and some upcoming activities that you can look forward to in 2018. So it is now my great pleasure to introduce to you Morris Landau, who's the Privacy Branch Chief at the Office of the National Coordinator. Morris, thank you so much for joining us.
Thank you, Lindsay. Good afternoon, everybody. Before I get started on the presentation, I have to read the disclaimers. It's just part of my job. The slides that I'm going to present to you are not intended to convey legal advice. Participants must consult with legal counsel for advice concerning state law. The information here is not to serve as legal advice, nor should substitute for legal counsel. The information presented is not exhaustive, and readers are encouraged to seek additional guidance to supplement the information contained herein. Lastly, the opinion I give is my own personal opinion and is not the official opinion of the U.S. Department of Health and Human Services. Now, with that going forward, why don't we get started on the slide deck, okay? Okay, the agenda that I'll be talking about is obviously, when you're talking about health privacy, you're talking about HIPAA, the Health Insurance Portability and Accountability Act, and the required uses and disclosures, or the permitted uses and disclosures of protected health information. We're going to demystify some of the privacy rule pieces of it, the role of state law, data aggregation regarding public health reporting, health oversight, another example of when you can disclose health information, and we can talk a little bit about resources. I know we mentioned data use agreements, and I'm happy to explore that further along if I receive questions. Next slide, please. So when we talk about HIPAA, the basic framework of the Health Insurance Portability and Accountability Act privacy rule, HIPAA only applies to covered entities. And covered entities tend to be health plans such as Medicaid, and health plans including employer and self-insured plans, if you're talking about Medicaid agencies, healthcare clearinghouses, which is a special type of entity, healthcare providers, that includes most healthcare providers who conduct certain electronic covered transactions, HIPAA transactions, and business associates. And basically what we mean by business associates are contractors who work on behalf of a covered entity. An example would be utilization review, data aggregators, those types of things. So that's who it applies to. It permits the exchange of protected health information as a general rule without the patient's permission for permitted uses for treatment, payment, and healthcare operations. And those are all terms of art under the privacy rule. There are permissive disclosures in some other categories at the discretion of the covered entity. These are not required disclosures, but permissive ones. When we talked about business associates, those are third parties who do work, who undertake the disclosure function on behalf of covered entities. When delegated by the covered entity, you have to enter a special contract known as a business associate agreement. A business associate agreement is what I like to call a specialized data use agreement. And there is some overlap when you look at a business associate agreement and a data use agreement. Lastly, when you're talking about the exchange when required by state or local law, these are public health activities involving public health authorities, local health departments, and healthcare oversight or agencies or other purposes. So let me quickly give you two examples. If in your state you have a required disclosure, for example, somebody has HIV and they're positive, and the state law requires that disclosure to a public health agency, to a local health agency, then obviously HIPAA does not prevent that disclosure. And the same thing regarding audits or some type of civil or criminal investigation that may involve HIV information. If your state requires that disclosure to occur, then obviously HIPAA does not prevent that as well. Next slide, please. So HIPAA does not prohibit the use and disclosure of mental or behavioral health data, including HIV or other clinical categories. So, for example, psychotherapy notes, that is the discussion between a therapist and their client. Correctional medical records would be the only exemption for non-disclosure of that information. In other words, you need a special permission to disclose psychotherapy notes or correctional medical records. But disclosure data, including labs, prescriptions, and appointments and procedures, there is one small carve-out restriction in federal law under the Veterans Administration for HIV-positive veterans and when the VA can disclose health information. The minimum necessary standard, which is a term of art under the privacy rule, means a need-to-know basis. That's what minimum necessary means for sharing for healthcare operations. Obviously, the minimum necessary rule does not apply to treatment, but the privacy rule, the HIPAA requires that patients or their legal representatives be allowed access to their own data. When the new law was passed way back in 2009 for high tech, which updated HIPAA, the privacy right of the patient is not just to receive their information, but also they have a right to direct that information to be sent to a third party, which may include an app and which may include HIV information. HIPAA very clearly is a floor and not a ceiling. It doesn't preempt state laws that are more restrictive and more protective than HIPAA. And obviously, in most states, HIV-specific state laws are generally provide more protections than the privacy rule, and in most cases, they require a patient's consent before disclosing their HIV status or AIDS status. Next slide, please. So as I mentioned, state laws or organizational policies may impose additional rules for health information disclosure. They may restrict disclosure of certain categories of information that require a patient's consent, or may require, some state laws have even additional confidential requirements. It may restrict the types held by state and local governments. It may enable broad collection, but not dissemination of health information. And we get this question quite a bit about state data banks and whether someone can query a state data bank. And that's very fact-specific and it's very state-specific. State laws may apply when HIPAA does not. For example, non-covered entities, housing authorities, when using or disclosing protected health information. I'm working on another event with HUD, and the question really becomes, can we share HIV information with non-covered entities? And usually the answer is governed by state law, but there are also a lot of questions regarding data sharing agreements and how that information can be protected, and I'm happy to discuss that further on. State laws may require the use of disclosures of PHI for certain purposes. Like I said, for public health or surveillance reporting that's required by law, healthcare oversight, state organizations, and law enforcement only in limited circumstances. Some states have provisions where if a person has been exposed to HIV, for example, there is a duty, a legal duty to notify potential infected persons, particularly employees of healthcare entities, a hospital or a doctor, but also potentially other folks who've been exposed may require that disclosure of information as well. Next slide, please. So, so when we talk about data aggregation generally means, under the privacy rule, protected health information created or received by a business associate in its capacity as a business associate of a covered entity. The combining of protected health information by a business associate with the protected health information received by a business associate in its capacity as a business associate of another covered entity does permit data analysis that relates to healthcare operations of the prospective covered entities. So in other words, you hire a contractor to do data aggregation, to do a healthcare known as a healthcare operation utilization review, that type of thing. Then obviously that will require a business associate agreement, which is a specialized data use agreement. Next slide, please. So, as I mentioned, healthcare operations is a very broad definition under the HIPAA privacy rule. That includes everything under number 1, number 2, and number 4. I just highlighted case management, care coordination, population activities. Those activities are not defined under the privacy rule, but it is left to the covered entity, the hospital, the healthcare entity, even Medicaid, the health plan, to define what those are and to give some leeway on when information can be disclosed to a contractor to perform these activities. Notice I also highlighted evaluating the qualifications of healthcare professionals, evaluating practitioner and provider performance, and health plan performance. Again, it's a very broad definition of when you can use HIV information that may not require a patient's consent. Next slide, please. So, as I talk about specific possibilities of use cases, a primary care or acute facility will send information to an analytics company that will require a business associate agreement. As a result, the question is before disclosing infectious disease patterns is whether state law will allow the disclosure to the ACME data analytics company, and the protected health information is sent back to the health authority to evaluate the data analytics to determine trends, population health, etc. Just sort of giving you a flavor of the data flow. Next slide, please. So again, in the next example, they're sending protected health information to a Medicaid agency contractor. Again, a business associate agreement would be required. The questions to ask is when you look at your state law is information about the Medicaid network, enrollment patterns, premium patterns. Can you disclose identifiable health information under your state law? And again, it depends upon what the purpose of that disclosure is. If it's collected and it's pursuant to Medicaid rules and it's required to do so, then most likely than not that a patient's consent would not be required. Next slide, please. So just sort of summarize on a table very quickly for FYI, it gives you sort of, if you're doing healthcare oversight, public health activities, doing data aggregation, it gives you a sense of how to go work through the workflow. And in all cases, under the HIPAA privacy rule, it's permitted. It gives a summary of what it collects, whether it is identified or not identified, and it's authorized and how legally it can be done, whether it's authorized by a business associate agreement, whether it's specified in your state law that is required. or whether it's permitted by your state, whether it's permitted under HIPAA, and you have to check your state law to see if it's allowable or not. Next slide, please. So there are certain safe harbors when sharing or disclosing information for data aggregation. And one is if the information is de-identified. So let me just be clear about what de-identification is. Under the de-identification requirements under the privacy rule, under the HIPAA privacy rule, there are two ways information can be de-identified. One is if 18 identifiers have been stripped of all their identifiers, name, address, email, etc. I'll just give you the site. It's 45 CFR 164-514. Or there's a scientifically based method by an expert that can also de-identify the information that is out there. If it is de-identified under HIPAA, the privacy rule does not apply, and therefore you have to rely on your state law to determine whether the information is disclosed. So truly de-identified information, you don't have to worry about the privacy rule. Now, when conducting research, and we get this quite often, researchers want to be able to query state data banks to determine population health, to measure trends, etc. There are two ways, basically, that a researcher can query state agencies for health information. One is through a limited data set, and that's another type of data sharing agreement. So there's, I like to call it, three buckets. One is a business associate agreement, one is a limited data set agreement, and the other is a basic generic data use agreement, which applies to covered entities and non-covered entities. All three are contracts that have specific provisions, and each one that has to be, then the privacy rule, let me say this again. The business associate agreement, the limited data use agreement have specific provisions that have to be in the contract. The data use agreement is something outside of the privacy rule, and it can be drafted in many different ways. The other point is that when you're conducting research, protected health information, generally patients have to consent, or the IRB, the Institutional Review Board, has the authority to waive consent. Next slide, please. So HIPAA supports interoperability, the exchange of health information. We've developed some fact sheets. The Office of the Chief Privacy Officer and the Office for Civil Rights have co-branded educational fact sheets for practical plain language examples with illustrations to supplement a blog series. The Privacy Office has launched a four-part blog series entitled Real HIPAA Supports Interoperability, and I have a list of those four blogs and, of course, some links for you to look at, some fact sheets about some general information on how protected health information is disclosed for public health activities and health oversight activities. And with that, I will wrap up my presentation. And of course, if you have any questions, there's my contact information. I just want to thank you for your time and attention to this presentation. Thank you.
Thank you, Morris. I would just really like to open up the lines or the chat box for questions.
You have been muted. To unmute, press. You are no longer muted.
Did everyone hear my call for questions?
Yes.
All right. Does anyone have any for Mr. Landau?
Just letting you know, all lines are now open.
I do have a question. Mr. Landau, this is a very complex issue for states to tackle. How would you suggest states go about looking at what data use agreements they have in place, whether they need a DUA, whether they need a BA? How should states begin assessing what their needs are in order to move forward?
Well, that's a great question. I think there's some basic There's some basic questions, no pun intended, basic questions you have to ask. One is, who is disclosing the information? What types of information are you disclosing? And to whom you're disclosing that information? And that will determine what type of agreement needs to be executed. The other question you have to ask is you have to think about the federal piece of it, as well as the federal law regulations, as well as the state laws. So are you dealing with a covered entity? Are you dealing with a business associate? And those terms are defined under the privacy rule, HIPAA privacy rule. And is that information being disclosed to a contractor? Is it being disclosed for another purpose? And then as you're thinking about it from a risk point of view, as far as liability, and possibly you have to think about other questions such as the security of the information in light of all the cybersecurity issues you have to think about. If there's a breach, who's going to be responsible? Who's going to be liable? And that applies to all agreements, not just business associate agreements, but also data use agreements. So there are a whole host of questions you have to think about when you're disclosing that information. So obviously you have to look at your own state law. And as a general rule regarding HIV information, most of the times you have to think about consent and whether you have the appropriate consent before disclosing. So there's a whole host of questions you have to ask.
Great, thank you. Do we have any other questions? I selfishly have another. One of the things that we hear a lot at NASHP from states is that there's discrepancy amongst their state entities and their legal teams and their offices about what their laws and what their state statutes and what they actually say and what they understand as being legally appropriate. Do you have any advice to states on how to level set amongst their own teams as to what kind of information can be shared?
Well, I think as a basic general rule, and I've looked at not all, but most states' HIV laws, as a general rule, it is a special protected area of health information, and most require a very strict confidentiality provisions. It varies among states. Most of the time, you need a special consent before disclosing information. I mean, as a general rule. And when you're disclosing the information, you really have to think about who is receiving it, because they're data stewards of that information. So you have to think about not just HIPAA, but also if you disclose that information to someone, how much do you trust that entity to protect that information? And that's a multi-layered question. That has to do with security, that has to do with breach, it has to do with for what purpose. Does that entity have a culture of protection of that information? You know, there are many lawsuits out there about HIV information being disclosed, and so you have to be extra careful about when disclosing that information. The other thing I would ask, and I do this quite a bit in my previous life when I was in the private sector, and that is there another way and a more protective way that you don't have to disclose as many identifiers? So a very quick example would be, instead of Morris Landau with HIV, it would be ML or just L, or do you have to use a name? Do you have to use the last 4 digits of your social? Do you have to, in other words, can you link that identifier by a special code, or does that information have to connect the person to that condition? I mean, these are all sort of best practices when you're disclosing information.
Great. Thank you so much. I'm sure we'll have more questions for you as the presentations go on.
Oh,
I'd like to move us to our next presentation, and this will be from Wendy Levy.
I believe we have Connecticut was asking a question.
Oh, I'm so sorry. I did not see that. Connecticut, act away.
I'm very meek. Morris, I just want to ask if there's any states that have successfully, I don't want to say relaxed because that sounds a negative thing, but have done some rethinking about HIV laws in their states and whether they're kind of a little too stringent at this point in history, and are re-legislating or. We're struggling with ours in Connecticut. Ours is
right. Go ahead.
I was going to say, in Connecticut, we struggle with that. Due to state laws, our Medicaid agency and our Department of Public Health, we can't link data because of state law.
I see.
And so I think when in the last HIV Affinity Grant, which was about data, was more about data linkage, or very similarly about data linkage. There was a lot of states that had those, but some states were, I think, trying to, bring them closer to HIPAA and not be super HIPAA.
Right.
So I don't know if you knew of any states that were.
Well, I can't point to any specific states, but I know that some states are less stringent than other states. My familiarity is with Texas and Tennessee and Georgia, more of the southern states. Ironically, those states are really concerned. Those are a little more lax than those in California, New York, Connecticut, and other places I've dealt with as a general rule. I will tell you that when I've worked in those states, the major concern, and again, this is a little off topic, but the major concern was making sure that those who are exposed, that means employees at hospitals, a stick or something like that, that those, or someone as a possible who's been a victim or something, make sure that those people were notified of any possible, that they were notified of any condition they were required to have some type of testing. But I can't think off the top of my head, state legislatures who were trying to lax their stringent disclosure information regarding HIV off the top of my head.
I can just throw in Oh, go ahead.
I was just asking in Connecticut too. I don't know if my sister agency is still on the phone, but I believe our RDPH gets the viral load data because it's a mandatory reporting disease. But our Medicaid agency does. We don't get that agency. We don't get the viral load information from our labs. We just pay, and we're not allowed to get that from them.
I see.
So we have a pretty stringent, because it's not. I guess because the way I think our legislation is written is because it's not needed for payment.
Right.
I think is how it's written. That would be why do you need to know that superfluous? You paid for the HIV test. I don't know. Wanted to throw that in there.
Yeah, it's very limiting. That's extremely limiting compared to other states I've seen. Again, I as far as proactively trying to open up the data flow, that's what we're trying to do at ONC. I can't give you any specific examples where there have been recently any specific changes to state laws regarding the disclosure of that.
Did we have another question? I heard someone else speak.
That was me. That was Wendy Levy. I think actually when I do my presentation, it might answer some of the questions that he was just asking about, because we don't have a relinquished or reduced intensity of our laws, but there are changes that have been made because of advocacy that have changed the interpretation of those laws and regulations. So maybe that, because we do, in my presentation, we'll talk about the interplay of viral load data and Medicaid.
Well, Wendy, that is an excellent segue. So why don't we move on to your presentation, Ending the AIDS Epidemic in New York State.
Okay. I'm going to make a disclaimer right up front. I'm Wendy Levy. I'm the Director of Medicaid Finance Systems and Research in the Department of Health. I am not a lawyer, so just want to be really clear. But I deal with all these things, and Mr. Landau's presentation was perfect because I will not have to explain a lot of the details of HIPAA or business associates agreements, but I'm going to go into details of some other types of agreements that we have in New York, and maybe it'll answer some questions about where we're at. I'm going to drive from here. So in 2014, the governor announced the end of AIDS, and what that did was identify all persons with HIV who remain undiagnosed and link them to care. He proposed to link and retain those individuals and treat them with antiretroviral therapy to maximize viral suppression, and you'll hear viral suppression being the key to this presentation. And then also provide individuals with PrEP for those who are high risk. From there, a task force was convened, and these task forces were grouped into all different sorts of areas, data and treatment and whatnot. And within that, they created these blueprint recommendations, and all these recommendations are currently being worked on by the Department of Health. And you can see that a lot of these revolve around the linkage and retention of individuals with HIV to HIV care to maximize this viral suppression. So that's pretty much what we're going to be focusing on. And then give you a quick overview of the managed care pilot that was implemented back in the summer of 2015, and then we're going to go into a lot of detail about how this played out. But just a quick overview of what we did. We took our Medicaid members that we've identified as HIV positive in the Medicaid data, and we matched them against the HIV AIDS Registry. From there, a pilot was launched that included 6 New York City-based programs, health plans in particular. Of those, 3 of them are our HIV special needs plans. These special needs plans are MCOs that are focused on primarily HIV positive individuals and their families. These 6 managed care plans accounted for 75% of all unsuppressed Medicaid managed care enrollees statewide. From there, we took the data that we were able to ascertain between the matching of the Medicaid and the registry data, and we were able to provide them with information on individuals who were not suppressed at the time that we sent this information out. Now, not suppressed, just real quick, is those with no documented viral load or those who are not suppressed at their last viral load. These plans are used, they took the data and then they took their own data along with the information that we provided, and this assisted them in linking and retaining these individuals into HIV care. We then expanded this pilot program in the next year to 13 additional managed care organizations statewide. So we call this phase 2, where we gave data to all 19 managed care organizations statewide. And we were able to show that the pilot program, so this large 75% of individuals who are unsuppressed statewide in managed care plans, had become suppressed by over 40%. So there was a success rate with this program, which got a lot of attention. So a year after this pilot began, 40% of the individuals who were unsuppressed were then suppressed. And so this is the basis for what we're going to be talking about in terms of what legal hurdles we had. As you can imagine, there were a large number of them along the way. Now, to give you some understanding of the New York State Department of Health and how it works with Medicaid, it's very different than other agencies and other states. The Medicaid agency itself is located within the New York State Department of Health. So that's the Office of Health Insurance Programs. They are the Medicaid data owners for the state. They own the Medicaid data. The data is reported through them, through their BAAs, and through all this other information, their intake system. It all comes into the Office of Health Insurance Programs. That's our Deputy Director for Medicaid. There's another office that was an offshoot of this group, that's the Office of Quality and Patient Safety. They handle Medicaid data for quality measures, and they are the future of our all-payer database that hopefully will be something you hear about in the future. Also, under the umbrella of the New York State Department of Health, the Division of Legal Affairs, and this is where all our lawyers are located in terms of those who are assigned to each area. So there's an AIDS lawyer, there's a Medicaid lawyer, and they don't always agree. So those are the people that we talk to about the legal issues. Also, under the New York State Department of Health umbrella is the AIDS Institute. We are responsible for the maintenance and monitoring and care of individuals with HIV, hepatitis, STIs, and also for the Drug User Health Program. Under the AIDS Institute, one of the groups is the Office of Medicaid Policy and Programs. That's the umbrella that I am in, and we handle all the Medicaid data analysis for the Institute. In addition, there is an area that it's a long name, epidemiology and evaluation, but within that holds the HIV AIDS Registry. So it's interesting because under the AIDS Institute, there's an area that handles Medicaid, and there's an area that has a registry. And these are not under the same areas, if you will, within the AIDS Institute. And the Medicaid office is a whole nother office away. So one would think it would be easy to get data and move things around, and it really is not that simple. It's just we're all under one big head of the New York State Department of Health. And this is pretty much, it's not the entire department, but it'll cover just our Medicaid entities within the Department of Health. So I just wanted to give you some kind of structure so you get where, when we have these data use agreements, data exchange agreements, MOUs, you know where I'm talking about. So we're going to back up a little bit and talk about an algorithm. Way back when, about 20 years ago, an algorithm was created in the AIDS Institute to identify HIV-positive Medicaid members within the Medicaid data. And it's evolved over time, and it's grown and changed with the way our rate setting works and the way things change in Medicaid every 5 minutes. But essentially, we look at complex criteria that are all combined in different ways that include things like diagnoses for HIV, pharmaceutical claims, inpatient and outpatient visits, OIs, and also enrollment in our special needs programs because those are primarily HIV-positive individuals. This algorithm is our bread and butter for our data exchange agreement with the Office of Health Insurance Programs, or our Medicaid entity agency within the New York State Department of Health. So in other words, the AIDS Institute holds a data exchange agreement with the Office of Health Insurance Programs, our Medicaid entity, based on this algorithm. And they allow us to see individuals that we identify through this code. Now, the complication of this is this information is loaded into the Medicaid data warehouse. It works with security roles and all that. But what's happening is they're moving to a new process for sister agencies, for outside entities, for people who need Medicaid data, and they're moving to a data use agreement that is more project-specific, more timeline-focused, and who the staffing are. So we're actually in the process of changing how we maintain our basic agreements and attempting to expand this to include hepatitis and STIs so that we can move into the other areas that we're responsible for. Right now, the only thing that we're seeing in Medicaid is HIV-positive individuals that we can identify through our algorithm. And this will become explained a little bit as we go along, that we need to take this data now that we've created through this algorithm and match it somewhere so we can have a little bit more confirmation about who it is we're actually looking at. So our HIV AIDS Registry, which I mentioned, is also in the AIDS Institute. We had to create a data use agreement with these individuals in the registry so that we could match our data together and we could identify what kind of appropriate usage of the data, what the third-party sharing data limitations are, data handling protections. It was very, very thorough, because there's a whole different, and I'm sure this is the case for any of you who've worked with both Medicaid and HIV, the laws governing Medicaid data, both the federal and state laws, as well as the federal and state laws governing HIV data in the registry are just completely different in some ways. And so we had to be able to protect both pieces of data. Once they're combined together, they no longer are just Medicaid data, but they're Medicaid and surveillance information. So it created a little bit more complexity in what information that we take out of this match, how much information we're giving the registry, how much the registry is giving back to us, and what we're actually going to do with this. Now, what's important here is that there was a change in the law in 2014 related to our HIV testing information, and it basically allowed for any HIV-related information to be shared with an authorized medical provider who is treating the individual. So this is going to now inform what's going to come next, which is once we match this data and we identify the total people. So this is really what you're looking at in this slide, is the number of individuals that we provided the first round to our registry, 73,000 individuals that we could identify. We then matched an 82% match rate. We then pull out our deceased members, and then we have about 55,000 remaining Medicaid members who we're going to look at and say, can we share those of the 55,000, can we share these who are unsuppressed with managed care plans? Now, it's a big question, and the law has changed to say we can provide this information to medical providers. The question is, can we share it with managed care plans? So first, let's look at what we got out of this data. We have, of these 55,000 individuals, 12,000 of them were found to not have achieved viral suppression based on their last viral load. This is you're actually seeing the information that we get from the registry, which is the viral load buckets who are actually getting their viral load scores, but we're actually getting about where they fall. And there was about 23% of these folks who are still not suppressed. We then look at all of those that are in a managed care plan at the time that they're not suppressed, and that was about 70% of that 12,000. And now we move over to those in a managed care plan. There are 74% who fall in the identified pilots that we talked about. There's 6 pilot plans. There's 3 very large New York City-based health plans, along with 3 HIV SNPs. So that's where that 75% of individuals who are unsuppressed in a managed care plan in New York State, that's where these people fell, and they were the focus of this pilot, where we were going to provide them some information about those who are unsuppressed. So what were we able to provide them? Remember, I had mentioned that once we match data, it's now both Medicaid and surveillance, but we were able to differentiate here what information is coming from Medicaid and what information is coming from the registry. So you can see that the viral load bucket for those unsuppressed members only, their viral load test month, and any discrepant death information is coming from the registry. And everything else is still considered Medicaid data, which we have in New York State no issue sharing that back with our managed care plans. But the registry data is different, and it is allowable to share with the medical directors, which was the interpretation, the state interpretation of the statute and regulations associated with the change in the law, that the medical directors of each plan was able to then see this information. So once we interpreted that, and this comes from the lawyers in our legal department, we're able to share the information with the medical director, but it's data and it's a large file. And what are we going to do with that? The medical director is not necessarily a person who can see or take that information in. So we were allowed to use a designee who we called a data designee for each medical director in each of the 6 plans. And those data designees were able to receive the confidential data, obviously encrypted through our secure file transfer system in the Department of Health. And they were able to use that information, but the medical director had to identify this person to us. So it was required that we go through all these processes to make sure that we're following the law. And then from there, we gave only, again, what information we thought they needed for linkage and retention to care. So we weren't giving out name, we're giving out a Medicaid ID, and that has to do with that need to know and the limitation of how much data you want to hand over to anyone. And then we had to give them additional information about what we wanted them to do with this and how we wanted the data handled, because it had to be in compliance with the law, changes to the law now that Medicaid and surveillance data are one. So each of these health plans signed a contract to agree how they would handle it and what they would do. Surveillance data was handled differently than Medicaid data, and it was having to follow the letter of the law and the regulation that stated that they could only share surveillance information with the provider, the actual provider of the individual who is in need of linkage and retention to care. So that's the pieces of information, our viral load bucket, viral load month and year, and the discrepant death information. We could only share it in the context of linkage and retention, whereas the Medicaid data had different regulations, but is not as stringent. So what we recommended to them is that they made it their own, which meant they take this information that we provide them about these individuals who are unsuppressed, and they mingle it, if you will, with their own data. So they can use their ARV data. They can say, oh, I know this person's not suppressed, but what is there in their viral load information that we actually have on file that will tell us that this person is unsuppressed, because they already share, the managed care organizations already share this information down. And we prefer, there's a preference, if you will, to not share the surveillance information directly so that we don't have this kind of breach. So we encourage them, unless they were sharing it directly with a PCP, that they should make it their own, and from there they can share that information with other care entities, because it's the same information they normally share with, let's say, health homes and other care entities. The managed care data can still be shared the way they do, but this is the way that we ask them to handle this, and this is our kind of workaround for how we're dealing with sharing of data. In phase 2 of this project, which happened a little over a year later, we expanded the project to the remaining 13 managed care plans, and we had to create MOUs for these folks because they weren't under contract. So again, it's going through the process of writing this agreement out and all the restrictions and how the data handling will occur and how the security will work. From there, it goes to legal. Legal approves. It's signed by the medical directors of the managed care plans. Once those are received, they can receive their data. We were able to show from time 1 for the pilots, again, from time 1 to time 2, a 43% success rate. And also by the time we looked at the data again, I think it was a couple months back, we were up to 45%. So this project of identifying individuals who are HIV positive to these agents, to these managed care organizations, and indicating that their viral loads aren't where they should be, in whatever way we needed to do this, actually resulted in a success in helping these individuals achieve suppression. So covering a lot of the issues all at once here, I kind of went through the project and where we had these hurdles and what we did, but just backtracking a little bit with some of the legal hurdles. We had some issues on the federal level. We actually were working with CMS at one point where we were talking to them about whether or not we could see more than just what was whittled down for us on the Medicaid side, because as I had mentioned, we have an algorithm. It identifies for us our HIV positive cohort. But there's need to look at things like PrEP, which is what we were originally asked to present on, but we don't have that quite yet. But we're being told at that time that it's a need to know basis, and the more limited data available to us is really all we need. And it's very similar, I think, to some of the issues around the 42 CFR Part 2 with the substance abuse data. They also have the same rigidity about the HIV data and the substance abuse data. So that's kind of one big hurdle. And then the second is, and someone mentioned this, the state interpretation of the federal law. So each lawyer is entitled to, that's their job to interpret the law the way they see that it should be interpreted. And this legal verbiage in the federal law that says the administration of the Medicaid program, you have to, this data is given to you for the administration. So if you're doing an evaluation project, that is not for the administration of the Medicaid program. But if you're doing it to improve the care of individuals, they consider that maybe part of the administration of the Medicaid program. So a lot of this is interpretation. And then the same, Medicaid has a different, each state is handling Medicaid differently, but we have a signed consent that all Medicaid enrollees sign when they're registered for the program, that they sign this that allows a certain amount of limited data sharing right off the bat. So we don't have the same issues as we do on the HIV side, whereas surveillance data just has a whole bunch of different laws and regulation interpretation issues, because our public health law in New York State, Article 27F, comes with some penalties for intentional breach of data. So there's just a whole nother set of rigidity around surveillance data. And once we match surveillance with Medicaid information, we consider it to be whatever the strongest protections are over the data. So CDC guidance and protocol over the registry has very strong guidance and protections that we have to provide all that information. How do we protect the data? Where is the data stored? How is it stored? So we have all these little things that seemingly would be no big deal to have viral load data, but if we have viral load data here in the Medicaid group, how are we treating that as if it were surveillance data? And it has to all be spelled out in these data agreements. So we first have our data exchange agreement with the Office of Health Insurance Programs. It allows us access to our Medicaid data. Then we have our data use agreement with our registry, which allows us to connect to surveillance data and then have some viral load suppression data available to us. And then we're working with the health plans, to which we then have to generate these other agreements, and in this particular case, they were MOUs. But all of these things need to be put in place, and then there has to be some wiggle room. So we have put some caveats in there to allow for amendments and how to put those in place and things of that nature. So I know I've covered a lot of information in a really short time, but these are some of the hurdles that we go through as we move along. We also have, in our data exchange agreement, we do have BAAs with other subcontractors as allowable by law, and those things have to all be put in place before any of this data sharing can really happen. So suddenly I've become pseudo-lawyer, but it's like I'm really not. But this is what my group does.
Wendy, thank you so very much. This was fantastic, and I want to make sure that we have time for our next presenter. So if anyone has questions for Wendy, please type them into the question and answer box, and we will get to those at the end. And so I want to make sure we have plenty of time for your Next presenter, who is Catherine Makehomer. She is from Michigan. She is the director of the Division of HIV STD programs, and she is also a member of our cohort. And so we're really excited that she could speak with us. So I'm going to toss it over to Catherine.
Good afternoon. Can you hear me?
Yes, ma'am.
Okay. Thank you guys, and I really appreciate the tie-in from New York State. We in Michigan have done similar matches with Medicaid data, looking at viral suppression among folks enrolled in our different plans, and mostly our data is looking at gaps in care and aggregate data reports at this point with Medicaid. But for my presentation today, I'm going to really focus on PrEP and using data to evaluate PrEP and gaps in PrEP in your state. In Michigan, Medicaid, I'm from the public health side, FYI, I'm on the public health side, but in Michigan, Medicaid and public health are under the same umbrella. It is just a very large umbrella organization, the Michigan Department of Health and Human Services. So today, for the agenda, I want to overview our state's PrEP programs, specifically how we use data to measure the success of our CDC 1506 grant. I have several different data-driven PrEP projects that we've done. Some have required data use agreements and IRBs, some have not. And so I just want to go over those so that you can see how different data points feed into how we measure success for PrEP and what we're doing in the future. Okay, did I successfully move my slides there? Yes, okay.
It doesn't look so, but I can do that.
Okay, I just moved them on my computer, but I don't think they moved for everyone. So can you move it to the slide with the Love Free from HIV?
It should be there.
It is there, okay. So Michigan CDC grant, which is 1506, is focused on PrEP, specifically PrEP media and PrEP awareness media in Wayne County, which is where Detroit is, so just in a specific part of Michigan. We have various print media, commercials, social media streaming, and we measure our program based on impressions and clicks on Pandora and various other media types that you can see below. Next slide. Oh. Okay. We have a lot of provider capacity projects, including collaborations with the Michigan Primary Care Association and the Michigan AIDS Training and Education Group. We have a clinical preceptorship program and a PrEP provider network. We have a community advisory board, and we do a lot of PrEP training to HIV counseling and testing folks, case managers, STI, DIS, or partner services folks. We do a lot of training on stages of change to assess PrEP readiness, and we do a lot of provider training. Michigan, I think, is a little bit unique in that we have our own 24/7 consult line where an emergency room or a private physician or an OB-GYN can call a nurse practitioner who specializes in PEP and PrEP and med-med interactions 24 hours a day to get consults on how to prescribe. And we use data to educate us on what and how to guide that program. Next slide. So we are trying to develop resources like a lot of other states with sort of limited dedicated PrEP funding. We have educational brochures, a payment guide, provider toolkit, various risk and readiness assessments, provider directories. We have brochures for clients and resources for clinical staff, both at local health departments, HIV testing organizations, and private providers. Next slide. So I think the real strength of our program is our evaluation plan. You can see sort of the high-level logic model here for our PrEP evaluation plan. I'm not going to go into it in detail, but it's there for you to look at. Next slide. Okay. Michigan's PrEP program won an award for meeting all of the standards of the evaluation plan, and we include feasibility standards, proprietary standards, and accuracy standards that are part of our evaluation plan. Next slide. Okay, go ahead. One more. Okay, so I'm going to just go over 3 or 4 data points that we found really useful in evaluating and driving our PrEP programming, both evaluating previous activities and moving forward. One is a provider survey. So we know that people who have STIs are at high risk for HIV. So we had an IRB, and you can see that in my project and in what I'm going to talk about today, there are various different projects. Some require an IRB, some require an IRB and a DUA, some require just an MOU, and some just require knowing someone to call. So I kind of spell those out in each of those projects. This required an IRB. We use STD surveillance data to pull Detroit area providers who diagnosed at least one case of gonorrhea or syphilis in the past 2 years. So we're looking at kind of more higher acuity STDs. Because if you've diagnosed gonorrhea or syphilis, you need to know what PrEP is, and you need to have basic awareness of how to prescribe it or how to refer if you're not comfortable for that. So as of today, we have administered 227 surveys out of the 551 possible providers. 19% of those providers say they discuss PrEP with almost all of their HIV negative men who have sex with men. 64% of the providers had heard of PrEP before. 42% feel comfortable providing PrEP, and 28% said they'd be willing to provide care. So you can see there's a little bit of a gap there in terms of initial prescribing and maintenance. 67% of providers say their clinic cannot provide information to clients on how to navigate PrEP copays, which is a great place where our program can step in for education. You can see that 59% of their clients are insured with Medicaid and 35% have private insurance, and in Michigan, Medicaid and nearly all private insurances pay for PrEP. So we're not dealing with a large uninsured population. But we did find in general that providers aren't asking about sexual health questions. They're not asking about non-genital STI testing, about points of exposure, and 40% of them said they don't think they have clients who are MSM, which I think is probably not correct. Next slide. Okay, this is just some of what the providers said their barriers to prescribing are. 54% had concerns about insurance coverage. 52% said they didn't have adequate training. 48% worried about the time needed to get prior auths. And then you can see 23% on lack of staff time and 22% on formulary restrictions. So these are just self-reported what their barriers were. So I am seeing the slide that says client surveys at the top. Is that what everyone else is seeing?
Yes.
Okay, thank you. So in addition to doing interviewing providers about PrEP and gaps in PrEP readiness, we also interview clients. And so we, in 2 years, in collaboration with the University of Washington, have administered client surveys about PrEP at our Detroit area Pride events. We have conducted 184 surveys in 2016, and we are kind of still waiting to get the results from the July 2017 versions. This required an IRB. So here again is some places where we measured how far we've come and some knowledge gaps. We found that 48% of respondents, only 48% of respondents knew that PrEP didn't protect against STDs. 7% had taken PrEP before. we found that 11% of white MSM were seen in LGBT health specialists, and 32% of men of MSM of color were seen in LGBT-specific provider, and 54% of them said that they had not talked to their doctor about PrEP. And this is their barriers to PrEP, strategized by white MSM, which is in the darker block, and MSM of color, which is in the lighter block. So you can just review that. We are also collecting clinic intake forms at the Detroit STD Clinic. I'm not sure how many of you guys are kind of aware of this, but the city of Detroit was one of the largest municipalities in U.S. history to file for bankruptcy. And when that happened several years ago, all of the public health services that are routinely provided at the public health department, like an STD clinic, could no longer be provided by the city health department. So we kind of stood up a Detroit Health Department in collaboration with Wayne State University. So that is serving as our STD clinic right now. And Dr. Heumann, who is also one of the participants on this working group, is currently, I think, the provider providing the largest number of PrEP prescriptions right now in Michigan. So one project we did there was, again, we needed an IRB, but we asked questions about where had people heard of PrEP for people coming into services at this clinic. Only 3 of 200 clients had heard that the clinic that they were going to go to actually provided PrEP. Most of them were there for routine STD care and didn't even know that they could get PrEP at that clinic. Okay, my slides are not moving forward again on here.
Can you see the Detroit STD Clinic prescribed PrEP slide?
Yep, I can now, thank you. So this is asking people who came in to that clinic, how did they hear that the clinic prescribes PrEP? And you can see that the vast majority of them only knew it once they got in there for STD services. And so we want people to be proactive, and so then that kind of changes our media and our awareness strategy in Detroit when people are not hearing about that clinic in other ways. We are also conducting analysis looking at claims-based data from insurance companies. We have worked both with Medicaid and Blue Cross Blue Shield. When we started this PrEP outreach grant, we wanted to know what our baseline was. And at the time, and still even today, there's not a one-stop shopping for PrEP prescriptions. And so you have to frequently go off surveillance data or claims data. So we had an IRB and a DUA, both with Medicaid and Blue Cross Blue Shield Michigan, to measure PrEP between 2012 and 2015. We looked at it by county and by sex and by race, and worked pretty hard to develop a palatable DUA that had cell suppression to measure privacy and kind of small cell analysis. That was especially difficult to work with. I don't know how many other diseases have prophylaxis, which is also treatment. So, you can't just have Medicaid pull data on people that are on Truvada, because people take Truvada when they have HIV, and so that developing that algorithm with Medicaid was complicated. But next is just a graph. So it shows PrEP or Truvada prescriptions by sex by year for Blue Cross Blue Shield and Medicaid. Okay. So the next thing we are going to do is use STD surveillance data for active PrEP referrals. We mined STD surveillance data looking for people who were HIV negative, who were at high risk of HIV. We identified 320 men who have sex with men with syphilis, 374 male partners of MSM syphilis cases, 349 male rectal GC cases, and 236 men that had 2 or more gonorrhea cases in 1 year. We are currently funding a PrEP navigator at the Wayne State University PrEP Clinic, and we're going to initiate a data use agreement and IRB to share that surveillance data with Wayne State University to conduct direct educational mailings, outreach, and possibly active referrals to those folks. Again, we will have to do that with Wayne State, but we do have approval to share that data with our local health departments once we develop more capacity and evaluation around this project. So, okay. We have also recently hired a public health detailer who will be a part of our staff. We will not need DUA or IRB approval to share this data, but we will, and I don't know how many of you are familiar with the concept of public health detailing, but really what we're doing is hiring a nurse who will be going to primary care, FQHC, sort of non-traditional partners for HIV and STD work to do quick educational sessions and drop off materials for PrEP with linkages to someone for more intensive TA, sort of like the pharmaceutical drug model. So it's really important to know where should we send this public health detailer. So we're going to use STD surveillance data to identify physicians who are diagnosing HIV cases or STD cases. And then we will link them to our Henry Ford medical consult line for more intensive support if they're interested. Like I said before, measuring PrEP is hard because it's not a reportable condition, it's not a communicable disease. There's no one place where it all sits. However, we do fund agencies who provide HIV testing, and the standard of care, at least in Michigan, is that if you receive an HIV test and that's negative, you should at least have documented PrEP assessments and PrEP readiness surveys to make sure that, and PrEP referrals if warranted. This is a funding agreement, and so it's part of our funding contracts now that all of these HIV testing sites have a data collection process. They're based on mini grants and contractual relationships. They send us monthly spreadsheets with data on their referrals, how many initiated PrEP, how many needed support services, and we're collecting limited adherence data at this point. And here you can see our targets and kind of what we have achieved. This is in 2017. So it's sort of a PrEP cascade, if you will. So in summary, PrEP surveillance is dependent on many disparate systems across insurance and claims data, STD, and HIV testing systems. The funds we have from CDC have a limited geographic scope. And while patient awareness is increasing, the provider engagement is not changing as much as we would like over time. And while provider awareness is increasing, the implementation of a sexual health model or primary care doctors talking about sex in a way that really helps them understand whether a person needs a PrEP referral or not is a limit. Assessing risk for PrEP is low and linkage and adherence support is lower. We need systems to identify gaps across the PrEP cascade and recommend support services for people to be adherent. PrEP doesn't work if you don't take it every day, and so we're really focused on that. Medicaid is an essential partner in all of those above items. Medicaid can help us with data, they can help us with provider education, and dedicated PrEP resources, at least in Michigan, are low, and the staff is spread out across multiple programs, so a consistent strategy is really important. We have really found that a program evaluator, a dedicated program evaluator is really important, and we've had a lot of work on these surveys from program evaluation interns from universities in Michigan. So if that's not something that you use right now, I highly recommend it. And I think that was my last slide. Lindsay, what slide are you seeing right now?
We're at discussion and questions.
Discussion and questions. Sorry about that. I'd love to open this up for questions at this time. If anyone has questions for any of our presenters or some discussion topics or their own challenges with their own PrEP programs in their state.
At this time, I will unmute all the lines.
You have been muted. You are no longer muted.
All lines are unmuted.
So I have some questions, and this is for both Wendy and Kate. I would love to know kind of what were some of the unexpected things that popped up along the way of implementing and develop these programs and these data use agreements and data sharing. What were some lessons learned that you could share with the other states on the call?
Well, this is Katie. I think one of our surprises, and I don't mean this to be dismissive in any way, is that people in Medicaid who have HIV or who are at risk for HIV were frequently doing better than the national or than the statewide average, and so we really wanted to share that as a success story with our partners in Medicaid and the managed care plans. I think
that's really fascinating. Could you talk a little bit more about why that was, or what you found out about that?
Well, and we measured Medicaid health outcomes the same as we would in terms of like our regular HIV care cascade, right? Gaps in care, viral suppression, and we just found that Medicaid was pretty consistently doing above the statewide average in terms of viral suppression and being in care. And so we thought that was really great. Typically you think of folks that are low income or on Medicaid might have sociodeterminants of health that might increase barriers. So we were really happy and really proud to share that with Medicaid, that they were doing such a good job with taking care of people with HIV in Michigan, which is exactly 1/3 of our total population. So they're exactly 1/3 of people living with HIV in Michigan are enrolled in Medicaid.
That's really great.
And we also thought,
Wendy, do you have something that you'd like to share?
I was just going to say that we have similar findings in that it's interesting, our dual population, so our Medicaid and Medicare population, have even higher rates of suppression than our general Medicaid population. So again, it mirrors the same thing. It's like the people who are worse off, you would think, are not doing as well, but it actually was the opposite that we expected, because and it varies depending on how you break out the population. About maybe 14 to 20% of our population are dual eligible. That their rates of suppression are definitely higher, than we expect. They're higher than the general Medicaid pop.
And this is Katie again. I think it's important when states, Michigan, we are so fortunate in Michigan that we're a Medicaid expansion state. And I think kind of success stories like this are so important to communicate beyond just the corners of the AIDS program, because Medicaid expansion is something that I really do think has contributed to this overall improved health for people living with HIV.
Do we have any questions from the audience? We're just at time, but I want to make sure that we can answer any questions that you have.
I have two questions. This is Michael Schenkel from Health HIV. I'm going to just jump back to a slide in the presentation on insurance data for measuring change. And I'm curious on why you see this big spike with Medicaid beneficiaries taking Truvada around 2014, and you don't see you see almost a decrease in 2014 with Blue Cross Blue Shield as taking Truvada for clients. And I'm curious on if you have any insights into why that is.
We really don't. I really can't say why that was. Our DUA for this was initiated in 2015, and we were really only given aggregate data, and it was very sort of suppressed. And so I wonder sometimes if there were some cell suppression issues in those previous years, or you know, we don't have names, we don't have a lot of demographics. We really got a table out of this, and so we don't have a lot of information. I think what we're going to do is we're definitely going to do it for 2016 and 2017, renew those IRBs, and see if there's any aberrations. And if there are aberrations, go back sort of to the drawing board on what the algorithm was, because the algorithm is tricky when you're pulling from claims data. It's just reality of claims data, right?
Yep, got it.
All right. Well, we are at about 3:30. I just want to let you know, first of all, thank you to all of our fabulous presenters, Mr. Landau, Ms. Levy, Ms. Maycomer. Thank you so much for all of the work you've put into your presentations and the availability today. We've really appreciated it. So those who are in the PrEP Policy Learning Series, we'll have a third webinar for you focusing on financing and reimbursement for Medicaid and other programs, and that will be probably the beginning to middle of February. And we will also have some other activities planned for you that have not been solidified yet. But if you have any questions or need any assistance, please feel free to email Erin Kim or Shana Linov, and they will be happy to help you. We will have a pop-up that comes up when you close out of the webinar. That is an evaluation for today's presentations and webinar, and we hope that you could fill that out and help us improve future webinars. So again, thank you all so very much, and have a great day.
Thank you all.